So thank you very much to the organizers of the Arab Thyroid Association for giving me the opportunity to speak with you today. My name is Paul Vanderlaan. I'm the Director of Cytopathology and Surgical Pathology here at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston, Massachusetts. And today I'm going to be talking to you all a little bit about the new Bethesda edition, the third edition for the classification of thyroid cytology, thyroid fine needle aspirations. So before I begin, here are my disclosures. These are my consulting fees unrelated to the content of this talk. In full disclosure, I am also the co-editor of the third edition of the Bethesda System for Reporting Thyroid Cytopathology, though all royalties from the book are donated to the American Society of Cytopathology. And finally, I am editor-in-chief of the Journal of the American Society of Cytopathology. So today we're going to be talking about thyroid cytopathology reporting, something that I'm sure you are all very familiar with. But if we take a step back, we have to think about, so what's the ultimate goal of these reporting systems? And, essentially the reporting systems must be succinct, unambiguous, and clinically helpful. And in doing so, we really hope to facilitate a clarity of communication, facilitating clear and effective communication, not only among cytopathologists, but also between cytopathologists, endocrinologists, surgeons, radiologists, and other healthcare providers. We really hope to provide clinically relevant information in so much that each diagnostic category has a well-defined risk of malignancy that's linked to a specific management recommendation. And of course, by having a thyroid reporting system where we're all speaking the same language, that really does allow for effective and reliable sharing of data between laboratories and translatable results from one laboratory to the other. So these are the ultimate goals of having these established reporting systems in cytopathology. Now, this was not always the case for thyroid fine needle aspirations. If we were to look at the landscape before the Bethesda system came about in 2010, you can see that this really nice review article that was written by my predecessor here at BIDMC, did a deep dive into the literature review of all published studies on thyroid fine needle aspiration from 1966 to 2003. And the punchline from this is looking at these publications, there was a very, very heterogeneous practice across the board with systems ranging from 2 to 6 or more different diagnostic categories in their reporting schemes. And this led to varying sensitivities and specificities in these reporting systems. And so really we needed a system where everyone was on the same page and reporting things similarly. So with that came the 2007 NCI Thyroid State of the Science Conference, a 2-day meeting in Bethesda, Maryland, where a meeting of 150 or so cytopathologists, endocrinologists, surgeons all came together to discuss the issues for thyroid fine needle aspiration. And from that meeting and from the papers and the working groups that came from that, the first edition of the Bethesda system for reporting thyroid cytopathology was published in 2010. If we fast forward into 2018, there were updates in the management of thyroid nodules that came from the 2015 ATA guidelines that were incorporated into the second edition. There were also advances in realization that molecular testing certainly played a role in the triaging and management of thyroid nodules, and that was included as well. And finally, with the introduction of the notion of NIFT-P, this indolent, well-behaved neoplasm that was managed in a less aggressive way, how do we deal with that in cytopathology? And so those concepts were also introduced into the second edition in 2018. Now, if we move forward, in June of 2023, the third edition of the Bethesda was published and is out and widely available currently. And so my goal is over the next couple of minutes or so to briefly go into what's new in the new edition. So very, very happy to report that this really does represent an international effort. We intentionally increased the number of authors and contributors from the second edition to the third edition. And in that third edition, a total of 67 different authors representing 55 institutions from 18 countries, 4 continents were included. And we also wanted the input of more clinicians and radiologists. So it's not purely a cytopathology focused reporting system, but one that is clinically relevant. What hasn't changed in any of the editions of the Bethesda book is that it is a very stratified, a risk stratified reporting scheme where there are distinct diagnostic categories that reflect the cytomorphology of the thyroid fine needle aspirates that have an implied risk of malignancy. So at its heart, this is a cytology reporting system based on the cytomorphologic features, cellular and colloid and background material that we see on these thyroid fine needle aspirates. So one of the major things that changed in the third edition was a simplification of the terminology. And in short, we settled on a single name per diagnostic category. And that's shown here, again, based on the cytomorphologic findings on those thyroid fine needle aspirations. The diagnostic category, it can be chosen of either non-diagnostic, benign, atypia of undetermined significance, follicular neoplasm, suspicious for malignancy, or malignant. And in the past, there have been options for multiple names per diagnostic category. And really, we saw that in the literature and in practice, this led to confusion. There were instances of category splitting where the former Bethesda 3 category that had an option of either atypia of undetermined significance or follicular lesion of undetermined significance, the intent was that a laboratory would select one name and stick with it. However, some laboratories started to use AUS for nuclear atypia, where there was a worry for papillary thyroid carcinoma, and FLUS for lesions that were more architecturally atypical, worry for a follicular neoplasm. And so other instances where suspicious for a follicular neoplasm versus follicular neoplasm had a splitting of the category. There was also confusion on the behalf of some of our clinical colleagues where two categories with similar sounding names, suspicious for a follicular neoplasm, Bethesda 4, versus suspicious for malignancy, Bethesda 5, both had suspicious in the name, but had very different risks of malignancy between the two that should be managed differently. And so really the intent was to transition from the flexibility that we wanted in the early editions of the Bethesda reporting system to more uniformity and clarity of communication in this third edition. And in this overview slide, I won't get into this in much detail, but it really does help align the Bethesda system with other international thyroid reporting systems where there's a single name per category. And again, overall, there's more similarities than differences across all of these reporting systems. And at the heart of these reporting systems, again, is the implied risk of malignancy. And this data has been updated since the second edition. So what we did is we did a deep dive into the literature, all of the studies published since the 2018 second edition of the Bethesda system, and looked at and gleaned the actual current most up-to-date risk of malignancy for each diagnostic category. And here we in this table provide not only the mean risk of malignancy, but also the expected range based, again, on large, high-quality published studies. And so with this, you can translate what you are seeing locally, and hopefully that correlates or corresponds to what the expected risk of malignancy is for each category. Again, with a usual management recommendation based on each category. Now, of course, these risks of malignancies are based on surgical outcome data, which really is the gold standard in pathology. So with the thyroid fine needle aspiration, with the diagnostic category, what is that surgical outcome? And of course, there are some issues with using surgical outcomes as that endpoint. We have to recognize that not all nodules are resected, especially for the indeterminate categories. And so this is a very nice meta-analysis of thyroid FNA series in both Western and Asian series. This is comprised of about 38 studies accounting for a little less than 150,000 thyroid fine needle aspirations. And from here, you can see that the resection rate really does vary based on the diagnostic category, from 11, 15% all the way up to 70, 80%, depending on the category. So there certainly is a risk of verification bias when you're really relying just on resected nodules. It's again coming back to it, especially those lower risk nodules such as benign or AUS that actually do go to surgery probably have some other worrisome features, which can lead to an inflated risk of malignancy for that category. There certainly is an additional layer of diagnostic subjectivity for the surgical pathologist, and so there are multiple degrees of freedom to account for. And lastly, from more of a laboratory standpoint, there certainly is a temporal lag between the thyroid fine needle aspiration and the resection, and that, as a lagging outcome indicator, can be difficult in compiling the data. Nevertheless, this is the data that we present in the Bethesda book. For the first time, we also provide data on the application of the thyroid fine needle aspiration Bethesda system for the pediatric population. So there have been a number of studies showing that these diagnostic categories can be effectively applied to thyroid fine needle aspirations from pediatric patients. And as we again show you here the implied risk of malignancy and the mean risk of malignancy for each diagnostic category. Now, if we were to graph these out visually, you can see that compared to the adult population, for each diagnostic category, the risk of malignancy is higher for those in the pediatric population. You can also see that that expected range is much broader, mainly because we don't have as many studies in the pediatric population as we do in adults. And so this really does mirror the fact that pediatric thyroid nodules generally are managed in a slightly more aggressive fashion, relating to the risk of malignancy for each one of these diagnostic categories. And then finally, we've, over the last 6-7 years or so, have more experience with NIFT-P. And so with NIFT-P, we again have updated the risk of malignancy, the expected decrease in the risk of malignancy if you exclude NIFT-P, which is a surgical disease, a surgical diagnosis, from those risk of malignancies for each diagnostic category. And then we do the math for you and basically give you the final mean estimated risk of malignancy if you exclude NIFT-P. And so here in one summary table, this shows you all of the updated risks of malignancy presented in the third edition of the Bethesda reporting system across each diagnostic category. What other changes have there been? Well, we have had some terminology updates that really reflect and mirror the 2022 fifth edition of the WHO Blue Book for thyroid tumors. And really, this is the gold standard for reporting of histopathology of tumors. And so we tried very hard to harmonize the terminology used in the Bethesda system to mirror that which we see and use in the surgical pathology side of things. And so that includes in the follicular-derived tumors, the benign tumors, the concept of follicular nodular disease and follicular oncocytic adenomas. In the low-risk neoplasms, again, NIFT-P terminology and the hyalinizing trabecular tumor. And lastly, in the malignant neoplasms, the change comes into this new category of the follicular-derived carcinomas that are high grade. And that includes the traditional poorly differentiated thyroid carcinoma, but also the differentiated high-grade thyroid carcinoma. Now, each of these entities, even though there's a little shifting around in the WHO reporting system for surgical pathology of thyroid nodules, they are not created new categories per se, but are described in each of the diagnostic categories where the cytomorphologic features would most aptly apply. So just to show just a few images of these changes. So in medicine, we were trying to get away from the use of eponyms in medicine. And so we no longer use the word Hürthle cell to describe those oncocytes, those thyroid follicular cells that have abundant granular cytoplasm, round nuclei with prominent nucleoli that on surgical pathology have a very pink or eosinophilic look to these cells. We now refer to them as oncocytes. And so you can have an oncocytic adenoma, an oncocytic carcinoma, no longer using follicular adenoma, Hürthle cell type as nomenclature. In addition, the concept of follicular nodular disease, benign follicular nodular disease, was introduced in the 2022 WHO classification to give a little bit more of an umbrella term that we can apply to benign thyroid nodules and not having to necessarily give the distinction of whether or not it's a follicular adenoma or if it's a hyperplastic nodule or an adenomatous nodule. Because we do realize that even in seemingly hyperplastic nodules or in multinodular goiter, many of them can be clonal. And so from a cytology side of things, morphologically they all look benign. And so it really does not matter on many levels, what terminology we use. And so now the recommended terminology and what we're encouraging to harmonize with the WHO is the concept and of these benign nodules as follicular nodular disease. And so you might see these in some of your cytology reports coming through. Another big change, again, is the formal subcategorization of the AUS category. And so if we look at the first two editions of the Bethesda system, the Bethesda 3 category, an indeterminate category, where you either chose atypia of undetermined significance or follicular lesion of undetermined significance, there were basically 6 different scenarios outlined. And so it was very complicated, and there were a lot of different ways in which an AUS or FLUS diagnosis could be made. And there was varying risks of malignancy with them. And so to simplify things, we finally formalized in the 3rd edition, using just the name atypia of undetermined significance, into AUS with nuclear atypia. In other words, those nodules where there is a concern for papillary thyroid carcinoma, more of the BRAF type mutated tumors, that has a higher risk of malignancy based on some of these scenarios, compared to AUS other. And AUS other is a lower risk AUS category. They tend to see a little bit more of the RAS pattern lesions in this category, and again can maybe be managed with accumulating data and use of this binary subclassification scheme of AUS in a more conservative manner. And so again, we've taken the multiple options of AUS or FLUS in the earlier editions and stratified them into AUS nuclear or AUS other. We do have, in conclusion, we do have a couple of new chapters that are introduced in this book, one on imaging and clinical findings and one on molecular testing. And so this clinical perspectives and imaging chapter is a really nice, concise overview of the role of imaging and ultrasound findings and clinical management of thyroid nodules. And this was really provided more for the help of the cytopathology community to understand the things that happen upstream of the decision to actually aspirate a thyroid nodule. And of course, based on the radiographic and characteristics of those nodules and the size of the nodule, there is an implied risk of malignancy using the TI-RADS type scoring. So again, this was introduced to the cytology community so that we can become more aware of again, those changes that happen upstream of us receiving a thyroid FNA. And the final chapter is a chapter on molecular and other ancillary tests. And this is something that I'm sure that the next speaker, Sarah Mason, will go into in the next lecture. But basically in this chapter, we provided a nice overview of the key molecular findings that we do encounter in thyroid neoplasia and malignancies. We do go into the purpose of testing, and we just describe briefly some of the different testing platforms, but in a very agnostic way. There's not a single molecular platform or testing modality that is recommended, but again, going over the pros and cons and what each type of testing modality offers. And if we look at the role of molecular testing, in the past, we've used this mainly to help triage those indeterminate thyroid fine needle aspirates of AUS or follicular neoplasm, to be able to triage those that are higher risk and really should be managed surgically versus those that are lower risk and can be observed or followed clinically. The other kind of emerging role for molecular testing is in patients with advanced stage disease, where we can find potentially targetable genomic alterations like BRAF V600E, NTRK fusions, RET fusions that can be treated with targeted therapies. And so there really is a valuable role for molecular testing in thyroid fine needle aspirates. And so with that, in this whirlwind summary, I'll hopefully have been able to convey that the 3rd edition really is an evolution and a maturation of the most widely used thyroid fine needle reporting system used worldwide. It is a simplified nomenclature where there's a single name for each category. We have updated risks of malignancy for each category. We've harmonized the terminology with the 5th edition of the WHO. We've refreshed and replaced about 40% of the images in the book, so it's the atlas gives cytopathologists a new look at these different diagnostic features. We updated the literature and have included new chapters on clinical imaging and molecular testing. And so, in total, this really represents the collective experience in evidence-based science from the international thyroid and cytology community. And so, with that, I'm looking forward to the open question and answer period live later in the session. But hopefully you found this overview useful in understanding the changes in the new 3rd edition of the Bethesda system for reporting thyroid cytopathology. Thank you for your attention.